Today let us talk on the management of lupus nephritis. I am Dr. Neeraj. Lupus nephritis treatment has undergone a significant paradigm shift from 2023 to 2026. We have moved from a sequential approach, waiting for the failure to happen, to an upfront combination strategy. Now first, when to suspect lupus nephritis in a SLE patient? We follow the low threshold rule. The classical nephrotic syndrome presentation is a very late finding. Now, modern KDIGO and ACR guidelines advocate for much earlier suspicion. So, routine screening is mandatory. Every SLE patient needs a urine analysis and urine protein creatinine ratio every 3 to 6 months. The silent flare, suspect lupus nephritis even with stable creatinine. Any new onset microscopic hematuria, especially dysmorphic RBCs or RBC cast, diagnose lupus nephritis. Low-grade proteinuria, a UPCR of more than 0.5. KDIGO emphasizes biopsy should be considered even at this threshold to catch a class 3 or a class 4 early in the disease. Any raising anti-DSGNA titers combined with a falling C3, C4 levels is highly predictive of renal involvement. Also, the novel biomarkers like urinary CD163. Recent 2026 data shows that it correlates better with histological activity than traditional proteinuria, potentially acting as a liquid biopsy. Let us look at the current standard of care for lupus nephritis. The biggest change in 2025 guideline is the endorsement of triple immunosuppressive therapy as a first-line option for proliferative lupus nephritis of class 3 or class 4 or even class 5. The anchor drugs for induction, you no longer choose between mycophenolate or cyclophosphamide as the only options. They are now the foundation for add-on biologicals. So the first option would be mycophenolate, target 2 to 3 gram per day. And option 2 would be low dose IV cyclophosphamide. The Eurolupus regimen uses 500 mg every 2 weeks for 6 doses. Or the triple therapy. Add-ons, standard of care now encourages adding one more drug in the upfront as an anchor drug. These may be available in your country, but when available, choose it. Like belimumab, based on Bliss LN trial, adding IV or subcutaneous belimumab to mycophenolate or cyclosporine improves primary effector kidney response and crucially reduces the risk of future renal flares. So, more than managing acute, risk of flares decrease. Then voclosporin, based on the Aurora trials, this novel calcineurin inhibitor does not require drug level monitoring like the previous calcineurin inhibitors and provide rapid reduction in the proteinuria. The constraint is that you should avoid voclosporin in eGFR of less than 45 ml per minute. Now the present regime is a glucocorticoid lean regimen. The era of high dose long term steroid is over. So in induction, IV methylprednisolone 250 to 1000 mg for 1 to 3 days is given, and then it's rapidly tapered down to less than 5 mg per day or prednisolone equivalent by the week of 24. Now let's look at the histological nuances. There are two things that you should understand the biopsy. One is the activity and the chronicity indices. For class 3 and class 4, which are proliferative, aggressive induction is required. While class 5 is membranous, if it is pure class 5 with nephrotic proteinuria, MMF with a calcineurin inhibitor, either voclosporin or tacrolimus is often preferred. Now let's define refractory disease. If there is no response by 6 months, switch the drug anchor MMF or cyclophosphamide, or consider obinutuzumab, which is a type 2 anti-CD20, which showed superior results in the Regency trial done in 2025 compared to the standard rituximab. Now coming to the maintenance, all this should be followed by maintenance, the long game. Duration maintenance should continue at least 3 to 5 years before stopping the drug. MMF remains the first choice. If pregnancy is planned, switch to azathioprine 3 to 6 months prior. Hydroxychloroquine is a non-negotiable for all lupus nephritis patients. Target a dose of 5 mg per kg per day to reduce the acral damage. So let's summarize. The standard of care is no longer just stopping the fire with steroids, high dose, and continuing steroids. It is using a triple therapy to prevent the scar. So we should biopsy earlier, taper steroids faster, and when available, use belimumab or voclosporin upfront to protect the nephron mass for the future.